Very much, Professor Sukuja. And as you rightly said, there have been two masterly lectures. Since Dr. Muthu finished last, I will just start the question from him. Going practically, we know that almost 15 to 30% of the patients develop donor-specific antibodies after transplant. You have given the concept that it is a continuum process, that possibly prior to transplant, he may be having whatever MFI which has increased. Now, do you have any protocol of monitoring the de novo antibodies post-transplant? Because the people who are going to develop, as I understand, that people who have got more HLA mismatches are people who are not getting adequate immunosuppression. They are the people who are going to develop de novo antibodies. Do you recommend any particular protocol that after transplantation, that if there was a lot of HLA mismatches, maybe every 3 months or 6 months or 1 year, we should check for the DSAs?
Yes, sir. That's a great question. Now, let me clarify that it shouldn't be viewed as there is no donors, there is no de novo antibodies at all. Everything is pre-transplant. No, it's not like that. There is de novo antibodies, but what I'm saying is beyond the point, we need to be careful that whether was this a low level antibody that was present pre-transplant that is sort of memory response and coming back after the transplant, or is it a new antibody? In a way, do we really care? Probably not. As long as we went ahead with the transplant because your cross-match was fine, and then there is a donor-specific antibody. Now, the question is, how frequently should I look for this and what am I going to do? Now, again, this comes back to the cost. I'm well aware that these are all expensive tests to do this back home. Here, for us, cost is not an issue, so we try to do it at least we do single antigen bead assays for the first 2 years, at least every 3 months. Or when there is an event, say when there is a BK virus infection and we reduce the immunosuppression, or for whatever reason, like severe diarrhea or bone marrow suppression, the patient's cell set is reduced, or the patient was non-adherent for a brief period. When we say non-adherence, sometimes here what happens is because of insurance issues to get drugs and when there is a delay, it is not non-adherence in the classical term, but if I'm asked to take 2 tablets of tacrolimus in the morning and 2 in the evening, I have short supply, I will go on 1 and 1 for some time. So the sort of lowish immunosuppression is the one that precipitates or activates the system, breaks the immunological sort of a prop tolerance that's there and brings up these antibodies. Now, repeated studies have established that non-adherence and reduced immunosuppression are the major reasons why donor-specific antibodies are coming up. Mm-hmm. So it's not fair to blame the patient for reduced immunosuppression. Sometimes we do it simply because there is an active infection or because the patient is not able to tolerate, but we need to keep in mind that these are the situations when donor-specific antibodies are coming up. So our protocol is every 3 months.
Now, are you going further down, like if you are doing the DSAs, we know that C1q binding is bad, or we say that IgG3 is bad, or we say C3D or 4D is bad. Are you subtyping it also?
No. So when you say are you subtyping, there are 2 major subtypings that can be done. One is, as you pointed out, G3 and find out the IgG subtype, G3 and G4. Or you can do C1q. C1q itself is controversial, whether C1q is a real thing that needs to be done, or it's simply a surrogate of a high MFI donor-specific antibodies. So most of the labs have not yet gone to do C1q or IgG subtyping as a routine. What we do is when we say that we pick up DSA at a low, let's say that somebody has no DSA at all, and when I do a 3 months DSA, it's showing up like 2,200, 2,400 like that. We do not do anything. We simply increase the immunosuppression. If the patient is on 500 milligram twice a day of CellCept, we increase it to 1,000 twice a day. Or if there is 1,000 twice a day, make sure that their adherence is not a problem. Increase the tacrolimus a little and follow the DSA again. Now, The moment it reaches around, it's our own cut point. Again, this, when I say some cut points, I made it clear that cut points are cut points. We need to talk to the tissue typing lab, and we need to come up with our own cut points. But at least when our cut point is around 6,000, 8,000 like that, we tend to do a protocol biopsies and see whether there is any microvascular inflammation. When you have microvascular inflammation, so a situation that I'm talking here is creatinine is completely normal, DSA is gradually increasing, and it's around 6,000, 8,000 like that. And at that context, no microalbuminuria in the routine lab analysis. Do surveillance biopsy, and surveillance biopsy shows microvascular inflammation as characterized by a glomerular G2, G3, or a PTC2, PTC3. We don't do a full-fledged AMR treatment, but we treat with IVIG and salmeterol pulse. And whether that's helpful or not is difficult to say because we don't have any randomized studies. But when we don't do any of this and simply follow these patients, nearly 30% of them between 3 months protocol biopsy and 12 months protocol biopsy develop transplant glomerulopathy and fibrosis.
Shortcut, because what you are trying to say that every 3 months you are trying to do the DSAs, even if patient has got normal creatinine, normal graft function. Now, if you are trying to pick up that DSA is gradually rising, that is the time you are resorting to protocol biopsy. And even if the graft function is appearing normal, we treat this subclinical or whatever rejection, what is occurring, what you say, MVI, that there is a microvascular injury, or you are trying to treat that. Isn't the so that is short of doing DSA every 3 months. Is there any other shortcut?
Short of doing DSA, is there any other shortcut? That's why I provided this molecular monitoring tools. Now, as of now, the shortcut is, okay, DSA is extremely expensive. I cannot do it. What should I do? Protocol biopsies. Now, protocol biopsies to see any microvascular inflammation. Which patient do I do protocol biopsies? Let's say that somebody is clean immunologically to start with. There is no flow, assuming that flow has been done and an initial DSA has been done, clean, and that is a male patient. There is no chances of sort of a pre-sensitization. So those patients, one may take the view that I'm not going to do any DSA in this patient. I'm not even going to do protocol biopsies because I'm not expecting anything to happen here. He is well compliant. He's maintaining his immunosuppression, full dose, nothing has happened. But you have a scenario. So when you say HLA mismatch is correct. But in the current era of calcineurin inhibitors, as long as you are maintaining a good level of calcineurin inhibitors and the patient is compliant with all the drugs and there was no reason the drug level was reduced, I don't think HLA mismatch alone is a major issue that you form de novo antibodies post-transplant. But if you can identify center-specific, our own high-risk patients who, say, for example, in our center, we say Black patients or anybody who had multiple sensitizations before, they may not be able to pick up by DSA at the time, or like I said, low level, like 1,000, 1,500, like that. So we are able to separate them into somebody clean, who are not expected to develop any immunological issues, or somebody who are expected to have a high immunological risk. So if you separate them into these two, even without doing a DSA, you can target on this group that is high immunological risk, either by doing protocol biopsies, or if this molecular monitoring tools becomes more cheaper as time goes on, like your AlloSure, which is your cell-free DNA, or your urinary mRNA profile, then you can follow this. And the moment there is an issue there, you can go ahead, either decide to treat it or do a biopsy and treat it.
I'll ask one question now from Dr. Raja. Again, as usual, wonderful talk. What is more important, you feel? Is it logically, is it the removal of antibodies or the stopping the formation of antibodies? Logically, I think you will agree, stopping the formation of antibodies is a more important component. How early the immunosuppression should be started? 1 week, 2 weeks, 3 weeks? Because we have to prevent the formation of antibodies. And a corollary to that, like you mentioned, the John Hopkins trial or Montgomery's trial studies, where they have not given rituximab at all. And their result at 1 year, 3 year, 5 year, the results are identical. So the Indian Society of Transplantation, where you are also one of the co-authors, have recommended the use of rituximab. But do you feel we can starting immunosuppression early, 2 weeks, 3 weeks early, and we can dispense with rituximab at all?
Thank you, sir. It's a very good question. I would confirm the questions again. One is whether the formation or stopping the formation or removal of the antibody is the key for a successful ABO incompatible transplant. The second one is when do we start the immunosuppression in these patients? Sir, to the first question, historically, an ABO incompatible transplant started with splenectomy as one of the desensitization protocol, along with plasmapheresis. So splenectomy essentially means, retarding the formation of antibodies. So none of them have been tried discreetly, but of late there are evidences where people have tried plasma exchange alone with ATG induction, and they have told that you could do transplant with basiliximab or ATG along with plasma exchange alone without need of rituximab. But yes, the shortcomings are these are not randomized trials, and there is only one trial which is compared immunoadsorption with rituximab. I did mention that. So that study says that immunoadsorption and use of rituximab both are good with respect to the outcome of the patients. So the bottom line as of now, I think the key is stopping the formation, along with that removal. You target stopping first. How do you target stopping first? First you give rituximab, stop the formation of antibodies, wait for 2 weeks, and then start the desensitization process. It could be a plasma exchange, double filtration plasma exchange, or an immunoadsorption. So that is question number one, sir. Question number two is whether it's 1, 2, or 3 weeks. So the day you give rituximab, you start mycophenolate mofetil at least, and maybe after a week or so you could start CNI. Although there are many guidelines which says that you could start both CNIs and MMF together and then go till the transplant. Some of them say you give 2 weeks of MMF prior to starting plasma exchange or immunoadsorption and 1 week of tacrolimus. So the bottom line is you have an adequate therapeutic level of tacrolimus at the time of transplantation, and you have MMF which is going on in circulation for about 2 weeks. So I think 2 weeks is a reasonable time. We will also have to factor one more thing is giving too much of tacrolimus and MMF in a patient with ESKD. Most of these patients develop diarrhea. With these patients are remaining on dialysis till they undergo transplant. So that is also a flip side to it. So we need to keep that in mind. Many of our patients do not tolerate 4 tablets of Cellcept, and you need to come down on the mycophenolate mofetil in them. And when you add CNIs, it gets complicated. So yes, 2 weeks is the answer at least as of now.
And as you mentioned in one of the slides,
yes, sir,
that the titer prior to transplant, that 1 in 16, this is the outcome, 1 in 16, 32 to 64, or 1 in 128. Does the titer, once we have reduced the titer prior to transplant to adequate level, 1:4 or something, does it have any implication on long-term graft outcome?
Sir, the slide that I showed was from the Japanese study which was published in 2000. Actually, the titers that I showed was just the day prior, it was just the day prior to transplant. Yeah. So they even transplanted with a titer of 1:128, and they did go on to show that 1:128, some people did well, but most of them did not do well. Only at the end of 5 years, only 29% had a surviving graft. So, once you say that, the titers, there are 2 types, opening titers, that is the titer before desensitization, that is also important. And also the titer which is prior to transplant, that is again important. In the sense that if you are having a very high opening titer of 1:256 and above, or 1:512 and above, the risk of rejection is high. And also the long-term outcome is poorer as compared to somebody who has got low opening titers. and whether the opening titer is significant or the pre-transplant titer, which among the two is more, I don't think we have a scientific data to support the conclusions.
I think next question is after Professor Gupta.
Thank you, General Varma, for allowing me some time. And both the talks, as usual, were excellent, and we learned a lot from both of them. Now, starting with you, Raja, since your center does both swab transplants and ABO incompatible, if you had a patient, which one would you choose first?
Yes, so it's a very pertinent question, sir, and that is why in the slide itself, in my first slide itself, I said a KPD greater than ABO incompatible transplant. At least for two reasons. First one is an ABO compatible transplant with a kidney paired donation is economical as when compared to an ABO incompatible transplant. And the second point is, the outcome, long-term outcome also, we know that an ABO compatible transplant is better. Third is the infection and the other complications like chronic infections like BKV are also higher in patients who undergo an ABO incompatible transplant. So I think it is swap only, sir. We also, try to find them, but most of the times we are unable to find a transplant in a patient who is O positive. So O is the...
Very true.
Yeah.
Very true. Very true. So by and large, if the message that you're trying to give is that we attempt to do a swab transplant if it is feasible and possible, but there could be occasions like particularly the O group, or you have someone who who can't find a swab transplant. There you would perhaps go in for ABO. But the data as of now, as you and Muthu have shown, is now that the results of ABO incompatible transplants is improving over the years, particularly the Japanese data, etc. So at what titer level, which just taking over the question from General Varma, beyond which you would say that, no, I wouldn't go in for an ABO incompatible? Would you say it's 512, or would you say 1024, or would you try at any level?
It's a very good question, sir, because, this question also came to our mind when we started the program. I'm sure that it would have been there when you were there at SGPG also. Sir, when a titer of, initially at PGI, we kept a titer of 256. So anybody above 256, we weren't actually taking them up for ABO incompatible transplants. Because we, for at least two reasons. One is, the number of plasma exchange required in them is humongous, and that time immunoadsorption was not available freely, and these patients run into a lot of infections. If somebody has to receive 15 sessions of plasma exchange, they will have to stay for 30 days in a public sector hospital. They are coming from a general ward to a dialysis room, going back. They are likely to develop more infections. So that is why we told that about 256 we weren't taking earlier. After the introduction of immunoadsorption column, we are taking those patients. But if I remember, at least in the 40 plus transplants that we have done, there is, I think, only one patient whom we took who had a titer of 5 and 12. Otherwise, most of them were about, I think it was median would be somewhere between 64 and 128.
What would Muthu's comments be in this regard? Dr. Muthu, would you like to say anything? Would you accept someone with the higher titer as compared to 256?
Yeah, no, I think I agree with the explanation provided by Raja. I don't think we would also go more than 256. But again, as he pointed out, we are more and more resorting to swaps rather than ABO incompatible. Practically, it's last several years we haven't done any ABO incompatible transplants at all.
At us, when I was in SGPGI, we have done several of these ABO incompatible, and the highest titer we took was 1024. But I think I regretted accepting that patient, because we had to do large number of plasmapheresis sessions and also use this filter as well. I mean, ultimately the patient had to pay a huge amount of money, and then we had some problems post-transplant. Fortunately, we were able to pull him through. But I think anything above 5, the most that we can take is a 512, on which I think should not be. General Varma, back to you.
I just wanted to ask Dr. Muthu, is the level of DSA prior to transplant, does it linearly correlate with the outcome?
No. So, as I said, sir, because this is not a linear scale. In fact, we need to, let me re-emphasize that MFI is not a scale at all. It is simply a relative value without any reference. But we try to, in published papers, try to provide some rationale for these numbers and say whether can we use that. But because of this C1q binding and the fact that not all antibodies are created equal, a 10,000 MFI doesn't mean that's a bad antibody, or 1,000 MFI doesn't mean that's a good antibody and nothing is going to happen. So it's extremely, in a large studies, it's extremely difficult to come up with some numbers and say that this is safe. And again, as I told, when we say threshold for what? The idea of these MFIs cut point were designed for surgeons. You need to do the surgery safely and come back without having a problem on the table. So if you have an MFI of a rough idea is that, at least based on our lab, when we have a 10,000 MFI, approximately around that range, our CDC will be positive. When we have around 6,000, our flow will be positive. So this gives, especially in the virtual cross-match field, where we have no time for we have no time for CDC or flow. We simply go by the existing DSA levels. Around 6,000, we will say, okay, this is probably flow positive, and then you need to make a decision that, are you going ahead or are you stopping? So other than that, for an individual patient, 10,000 may be completely fine because it may not be a C1q or it may not be a proper antibody at all. Remember that, as I told, this is all denatured, reacting against a denatured antigen. At the same time, 1,000, 1,500, we may say it is lower than our cut point, but over time, there can be a slow chronic endothelial injury which results in transplant glomerulopathy.
So how do you resolve this?
That becomes
Are you going by the type of antibodies?
That's what becomes extremely challenging. In other words, when the pre-transplant DSA is 0, and then we continue to, if there is a high immunological risk like an African American or a woman or something like that, and we continue to follow, as long as the titers and as long as the MFA values continue to remain, the vast majority will have 0. Then we are fine. The moment we have some amount of DSA, in a way we don't look at the absolute MFI values. We try to do a surveillance biopsies to see what happens and catch them early. But whether this simply giving IVIG and steroids to mitigate the microvascular inflammation, is it helpful? We need larger studies because these are all sort of resistant plasma cells that produce antibodies. It is not like a one-shot cell-mediated rejection. This is sort of difficult to treat by our conventional therapy. So that's why I didn't focus on therapy, because each of us will have a favorite protocol and a favorite drug. And the bottom line is none of them are really helpful.
Can I ask one question, General Varma, if you permit me?
Please.
Just a question once again about ABO incompatible transplant. Maybe Raja can take it, or to say, can you say that if a patient who's had an ABO incompatible transplant has remained free of any graft dysfunction for, say, X number of weeks, what would be the time frame after which you would say that this fellow has had an accommodation of the graft or whatever it is? Raja,
you're muted. Raja,
Sir, it's again a wonderful question. So
maybe I can provoke you by saying that maybe somewhere around 3 to 6 months is the cutoff for that.
Sir, accommodation, however, there was one question, one of the attendees had actually asked that in that I had written, sir. So, accommodation can happen very quickly, sir. It can happen within 1 to 2 weeks also.
2 weeks.
And 1 to 2 weeks itself, you can have an accommodation, and up to 75% of them can have C4D positive with respect to an ABO incompatible transplant. With respect to monitoring the ABO titers, and I think 2 weeks should be fine. There have been disputes between 1 week, 2 weeks, and 4 weeks. it's an unsettled dispute, but again, after 2 weeks, it shouldn't be of any significance. But yes, after most of these O group transplants are also HLA, a sort of HLA incompatible transplant, like you don't have 100% match in between them. So it could be very much that they could be developing anti-HLA antibodies. We had 2 patients who actually had ABO incompatible, who had rejections. And, we were thinking of it's probably related to AB, but once we did the DSA, we realized that they actually, stopped the drugs in between, and they actually had a 10,000 plus donor-specific antibodies. And the ABO titers were less, it was 1:16, but I think that should be fine. But it was actually the anti-HLA antibodies in both the patients, which was actually causing the rejection. They had chronic rejection plus an acute worsening kind of situation.
Just to Raja, the point about the infections, what you were mentioning, because all these studies what were done prior to this, that they have used significant amount of ATG. All the studies have used 6 milligram, 9 milligram of ATG. Now you have come down to just around in India 3 milligram of ATG. There is no data which is compared 3 milligram ATG. Is really the infection rate very high?
Sir,
the second question I'm asking you is...
but are we using ATG? Most often you use basiliximab, after.
It depends. There are many centers who are still using ATG. Because previously people were using rituximab 500 milligram. Now basically people have come to 200 milligram. Calcutta group is using 100 milligram. And the rituximab dose has come down. Likewise, the ATG dose has come down now. Because the infections, whatever were reported, they were with higher doses. I don't know, with the present scenario, what is the picture? And secondly, how long the C4D positivity will remain in the graft? There's a part of accommodation. Because why I'm saying, today only, but we did a biopsy. I was just seeing the biopsy. This patient had ABO incompatible transplant 3 years back in 2018. And on the biopsy report, we found diffuse C4D staining throughout the biopsy. And it was full of neutrophils. It was more suggestive of acute pyelonephritis. But the pathologist who saw it first, he got frightened. He said, such a diffuse C4D positivity all over, that please tell me, is it ABO incompatible or something? That means even after 3 years, we saw today that C4D positivity remained through and through. Your comments on these 2 points.
Sir, I will take up the 2 questions, and I would also ask Dr. Muthukumar's comment on the 2 questions. So regarding ATG and infections, sir, we are currently, our unit uses ATG as the induction agent. We scarcely use basiliximab. And recently there was an analysis done, which was done across India by one of the pharmaceutical, if I recollect, where they looked up into the infection rates with ATG. And what they found was the infection rate, even with 3 milligrams of ATG, was significantly higher as compared to patients who did not receive any sort of induction or received basiliximab induction.
I hope the drug was not by basiliximab company.
Sir, I wouldn't go into details of it, sir. Sir, the other flip side to this is many a times, although CMV prophylaxis has been recommended in all the patients who receive ATG induction, at least, but it's not being followed up 100% in patients who receive ATG. So the incidence of CMV goes up. Once the incidence of CMV goes up, you have incidence of other infections going up like UTI and the tuberculosis and fungal infections, Candida. So these infections also go up simultaneously. So that is one part of it. So if you're using 3 milligrams of ATG, yes, it incurs some amount. If it is doing some good with respect to the immunology part, so it should be doing some harm. If it isn't doing any harm, that means it's not working. So it's that way at least. Second one, how long does the C4D stay? It starts about 1 to 2 weeks and it's there, it's accommodated, sir. It is there forever. It's that kind of situation. Okay. So I would pass it on to Dr. Muthu for comments, so is more wiser.
Yeah, so this question of ATG, yes, there are no high quality studies comparing 3 doses versus 4 doses versus 5 doses. If I recollect, there was a 2017 paper in Clinical Transplantation I think it's from Iran. They did like 90 or 100 patients where there were 3 ATG groups. One was a 4.5 milligram, 3 doses, like 1.5 milligram every day. Another one was 4.5 milligram single dose. Another one was 6 milligram per kilogram body weight, I think in 3 or 4 days. So the traditional one can say this as a single dose 4.5, 3 doses of 1.5 each and 4 doses of 1.5 each. I think the efficacy was more or less similar, meaning that the acute rejection rate was not different, but there were less complications in the 3 milligram dose compared to 4.5 milligram. So one can say that we do not know the exact dose that will prevent. So especially for low immunological risk patients, probably ATG is not needed, or if at all needed, 3 doses should be sufficient.
I think we hand over to Professor Sakuja.
But Raja, would you use ATG as an induction in ABO incompatible at all?
Sir, our usual protocol is ATG for all the patients, and we have, covered it ABO incompatible also with ATG. I do agree that the risk of infections with
because at our center we were using bacilliximab.
Yes, I know. Sir,
most of the centers in India are using still ATG.
Because bacilliximab does as well. I mean, since you are already giving rituximab, I don't think there is any need for giving ATG.
Yes, sir. I personally agree upon that, but it's a unit protocol, and there could be many other factors which decide upon that.
Just one brief question to Raja: Are you using IVIG or not?
We are not using
in your protocol.
Right from the patient 1, we are not using IVIG.
You are not using it currently.
Yes.
Okay. Right. And are you using double filtration plasma exchange?
Sir,
or
to the best of my knowledge, that facility isn't available, sir.
Isn't available. Yeah. Right. Okay. Are there any other questions from the participants, those who are listening into this program? Are there any last-minute questions?
So there are several questions in the question and answer box. Actually, there are 5 of them.
ABO part, I've answered all of them.
Anything left that has not been answered?
Oh, sorry, I didn't see this question and answer box.
Even I haven't seen it.
Does SAB tell us about antibody, whether it is complement binding or not? Answer to that is single antigen bead alone is not.
Yes.
In fact, if I can extend on that, I mean, we attribute too much effect to complement, but more and more data is coming in that this transplant glomerulopathy or the chronic antibody-mediated rejection is probably a ADCC mechanism, meaning that it's an antibody-dependent cell-mediated cytotoxicity where NK cells are involved and not complement-mediated. So complement may not be the mechanism for everything.
Mm-hmm.
Precautions from the beginning to get rid of de novo DSA. The 2 most important things are make sure that the patient is compliant with all the medicines, not miss a single dose, and make sure that we as physicians are not reducing the immunosuppression for whatever reason. Now, that is easier said than done because you can have a bone marrow suppression, severe diarrhea, not able to tolerate. And again, over, say, X number of months after transplant, at least first few months, we are all very comfortable, but X number of months after transplant, 1 year, 2 years, what is the ideal dose? How do we monitor this? That is challenging. That's where all these molecular tools, as and when it becomes cheaper, it will be beneficial to target or personalize immunosuppression based on that. And one can use like a CD4 functional assays or your DSA titers and other things. So that's one way to monitor. So the best way to prevent de novo DSA from coming is to simply make sure that the immunosuppression is adequate. The next question is, what is the role of cell-free DNA in detecting rejection during immediate or early weeks of post-transplant? How long do cell-free DNA prevail in the blood following an episode of rejection? Will it affect diagnosing the second episode of rejection happening within a shorter interval from the first? Now, cell-free DNA, plasma cell-free DNA is catching up a lot. The AlloSure, which is the CareDx company, their cut point is 1%. So the donor-derived fraction is you simply take a plasma sample, measure the free-floating total DNA there, and get if the donor-derived fraction is more than 1%, then it is considered as significant donor injury. For this, the donor HLA information or the donor genotyping is not needed. Simply, they go by an algorithm in which they are able to say that based on single nucleotide polymorphisms, what proportion of my DNA that I have in my hand is donor derived. And that's where they come up with this 1% cut point. The problem with donor derived DNA is that this is not, it is not mechanism based. Any type of injury to the organ so you cannot differentiate whether it's an AMR or an ACR or an ATN. Fortunately, it so happens that in ATN, we don't have that much of DNA release. So far they have been fine with this 1% cut point. So that's where we are. And it may be useful for monitoring, but we need more studies to say that how frequently this donor-derived DNA should be used. One more question. Standard test to order pre-transplant in a low-risk or high-risk recipient. Can you clarify that? What is meant by standard test? Dr. Sandeep Kumar Panda?
Possibly he's asking that CDC, we are doing flow, we are doing
flow
DSA also.
Yes.
If it is a low risk, should we go ahead with DSA also? Possibly in US, 100% DSA will be done.
Sitting in New York, unfortunately, I cannot answer that question. We do everything for all patients. So I think it should be a local institutional policy of who are your low risk people and who are your high risk people and what are you trying to do to them.
I think I'll take up that question because,
Sure,
local
please.
level. So, because we have had bad experience. So, somebody who had a bad experience can speak better on the protocol. So, we actually had a rejection rate of 25 to 30% a few years, 2-3 years ago, we had a rejection rate. And what we were testing in all the patients was only a CDC cross match. We were not doing anything else. And the patients who had positivity for CDC, we used to do some plasma exchange, proceed with transplant. But after that, what we believed was 30% was too much. And then we introduced flow cytometry and also DSA. DSA has been done in patients who have sensitized. Sensitized definition is pregnancy, any blood transfusion, or any history of recurrent infections, IJV, HCV infection, or any other infections. We did DSA. With incorporating flow and the DSA, we have come down from about 25 to 30% to less than 10%. So I think you should go more by your center's experience rather than just hearing to some other center and deciding upon what to be done. In somebody who is sensitized, I think you should use all your tests because it is worthy to put your money before the organ is placed. Rather than, you have put an organ, develop rejection, and then you start plasma exchange in the patients. I see it that way.
I fully agree with you. I think when you are trying to, in Indian scenario, when you are willing to spend 6 lakh, 8 lakhs on transplant, it is worth doing DSAs also for 20,000.
Yes.
So it is worth doing that. As a unit protocol, it should be that you are going for CDC, you are going for flow, you are going for DSA also.
If I can add on to what Raja said, that point is well taken. And especially when we say immunosuppression, sometimes we have a tendency to say that, okay, we just discussed about 3.5 milligrams and 5 milligram ATG. We focus on minimizing immunosuppression in the beginning, forgetting that when these patients develop rejection, the eventual immunosuppression that's required to pull them back will result in total immunosuppression that's probably more than what we had anticipated. So in a way, it's better to target the higher immunological risk patient initially, sort of give the maximum immunosuppression initially, and then follow them at a stable level so that they are immunologically, they are fine.
Hello.
Right. So I think we have exhaustively covered the subject. I'd like to thank both the speakers.
Professor Sakuja, can I ask you one question?
Yes. Okay.
Just a question, not related to the topic, that should we vaccinate COVID vaccine to our transplant patients?
These are live attenuated